Hello, I am Dr. Mirela Cerneanu, and I welcome you to the Wellness Optimizing Warrior MD podcast, the WOW MD podcast. I am not your typical wellness coach, and this is not a typical wellness podcast. Here, I'll discuss educational facts about health, hormones, intimacy, anti-aging, and beauty trends, all very hot topics, to empower you to make great choices when it comes to your health and to your body. I want you to go, wow, I did not know that. Or, wow, this is going to make a great difference for me. Our healthcare system is broken and it needs a revolution. You and I can start one today. I am willing to share my knowledge with the world if you're willing to listen. Let's get started. I am excited to continue this topic of fertility treatments, and I am going to pick up exactly where I left off in the previous episode. I talked about the normal, delicate balance of our hormones. And I dived in the last episode into the options that we have available with vitamins and minerals, and how can we bring our hormonal balance into play? How can we improve the semen analysis to look better? How can we improve the quantity and quality of our eggs and of the sperm? So in this episode, I'm going to talk about maximizing how to maximize the fertility potential of our reproductive organs, specifically for women. And I'm going to start with the very key of those fertility organs, reproductive organs, which is the fallopian tube. If you don't recall or you haven't listened, go back a little bit. I dedicated an entire podcast to the fallopian tube, a delicate tubal structure that connects the uterus to each one of our ovaries. So we have a right tube and a left tube. I discussed how the fallopian tube can get scarred and closed off due to various inflammatory processes and scarring and other inflammation issues, including endometriosis. And scarring and closing off of the tube, it's a big problem because it literally blocks the communication and the meeting of the egg and the sperm. Most often, the problem with the fallopian tube is a consequence of a disease process that involves in various degrees an inflammatory process or an infection. And both the inflammation or the infection will create adhesions, which kink the tube, can also cause fibrosis, scarring, and ultimately can actually seal off the tube from the inside. Now, usually, and that is a problem, the tubal dysfunction has no clinical signs and symptoms outside perhaps of the initial inflammatory or infectious insult, which might be way in the past and something that a woman might not even remember. And it will remain undiagnosed until actually the woman tries to get pregnant. She finds out she cannot get pregnant, will seek medical advice, and then the doctor will say, let's do this test to see if your tubes are open. Then boom, we find out the tubes are not working. So let's talk about this issue. Once the tubes are blocked, the question is, can our body reopen the tubes? Now, that is an answer that science, or at least modern medicine, does not quite have at the moment. However, quite a few women have been told that their fallopian tubes are closed, that they will likely not be able to conceive naturally, or they will have a high chance of an ectopic pregnancy, which will doom the fallopian tube on that side, and they still got pregnant with a normal pregnancy. So modern medicine is very well known to give very definite answers sometimes that are very negative and can be wrong or incorrect, because we, the doctors, do not take into account the body's natural healing processes. And we presume that once an organ is sick and doomed to failure, it cannot heal, repair, or resume normal function. Now, I am talking about the fallopian tube problems, so just as a reminder, the best test to tell a woman whether or not her tubes are open, it is a hysterosalpingogram. This is a rather simple test, but somewhat invasive. The radiologist will monitor the progression of the dye through the cervix, into the uterus, then throughout the tubes, and it will show whether or not it's spilling into the pelvic cavity where the tubes are dilated and kinked, or it doesn't go to the tube at all, etc. So I did talk about this test. in the podcast episode where I addressed the tubal fertility factor. Why am I revisiting it? Because the hysterosalpingogram, the test that tells you that your tubes are open or closed, can also be a therapy. Let's presume that your tubes are slightly stuck. Well, the pressure from the actual dye can actually open them. It is well known that a woman will increase her fertility chances in the next 6 months after the performance of this test. So if you get a good result on the test, then the best fertility possible is in the first 6 months after the test is done. Now, let's talk about modern medicine solutions to open or recanalize closed fallopian tubes. Now, usually that's a surgery, and it can be done laparoscopically, a minimally invasive surgery performed through a very small incision in the belly button. And during this type of surgery, the camera can give the surgeon a good view of what might cause the tubal blockage. We will inject the blue dye through the cervix into the uterus, and then we observe its progress through the camera from the uterus into the tubes, and the doctor can understand the tubes are closed, both of them, just one. Maybe the dye might accumulate and distend a tube, showing exactly where the blocked part is. Now, the diseased part of the tube can be removed, and then the remaining healthier parts of the tubes can be sewn back together, which in medical terms is called reanastomosis. Putting the ends back together, this reanastomosis, it's also done when a woman had a tubal ligation and would like her tubal ligation reversed. Tubal ligation, it's a sterilization procedure that's done by many women when they're quite young, after they had 2 or 3 or 4 children, and then they change their mind, either personal drama or new marriage, which is most of the time it's new marriage, but there's a significant regret associated with tubal ligation, sometimes as high as 30%, and many women would like their tubal ligation reversed. Now, the chance of a live birth, so having a live child after such a procedure, vary greatly, and it depends on whether the tube is healthy, just needs to be put back together because it was cut off, or whether the anastomosis procedure is done for a tubal blockage from an unhealthy inflammatory process. Now, if the surgery is done to reverse a previous tubal ligation with healthy tubes, then the chance of live birth is estimated to be between 50 and 80% of the reanastomosis surgeries. However, if the surgery is done for a diseased tube, then the chance for live birth varies widely, and it could be as low as 10% and as high as 80%. Depends on severity of disease and the skill of the surgeon. Now, remember this. The fact that the tube is open on the test that is done 3 months after the surgery to recanalize the tube or reopen the tube does not mean that the tube is also functioning properly. There is a very high risk of ectopic pregnancy for women who undergo tubal surgery to reopen the tubes. And remember, I said the ectopic pregnancy is a pregnancy located outside the uterus. And for these women with anastomosis of their tubal ligation or a diseased tube that has to be excised, a segment, and then the ends put back together, for many of them, the pregnancy will actually be in the tube. And it will be a tubal pregnancy. So women that have tubal reconstruction surgery need to follow up with their physician as soon as they get a late period or any sign of an abnormal period that suggests implantation bleed or a possible ectopic pregnancy. It needs to be evaluated. So let me discuss another type of procedure that's much less invasive than the laparoscopy repair of a damaged tube. This is called a fallopian tube recanalization. This is not a surgical procedure. There's no cutting involved, and it's mainly performed by an interventional radiologist. And we use the term recanalization to mean reopening. So during this procedure, the interventional radiology physician will likely place a speculum, will open up the vaginal canal, find the cervix, then he will pass a catheter, a very small plastic tube, through the external opening of the cervix, then into the internal uterus, and then inject a contrast dye, just like I mentioned earlier with the hysterosalpingogram, through the catheter, while a monitor is placed over the patient's abdomen. And the doctor's looking on the screen and following the progression of the dye. Once a blockage is visualized, either one tube or both tubes, then the physician will actually thread a smaller catheter through the initial catheter. Then that catheter is threaded into the fallopian tube to try to clear the blockage. Now, obviously, this procedure is done under sterile conditions. It takes about half an hour, maybe an hour. It requires an antibiotic like doxycycline twice a day for a few days. And usually we recommend that to start a few days before the procedure. It is uncomfortable for most women because opening the cervix with the catheter and then opening the uterus with the dye and then opening the tube with the catheter can cause discomfort. You might have an IV placed so the doctor can administer medication to relax, to sedate you, and for pain relief to make you comfortable. Most likely you will need a preparation like a surgery, but there will be no surgery, no incision, meaning you won't eat anything the night before, and this will have to be done on an empty stomach in a imaging center. Now, the limitation of this procedure is the same as the limitation of any laparoscopic surgery that tries to restore and open the fallopian tubes. The laparoscopic surgery, where the tubal recanalization might unclog the tubes, but it might be temporary because the procedure will not, unfortunately, reverse the process that caused the tubes to become blocked in the first place. And there is a significant chance that after both the laparoscopic surgery to reanastomose and put the tubes together, and after the recanalization procedure, maybe 30% or more of patients will close their tubes spontaneously within 6 months because the inflammation, the infection, the fibrosis, the scarring might be ongoing and lead to the same problem happening again pretty quickly, depending on the severity of the ongoing process. So ideally, we would identify that type of process and also address it at the same time. So here's the question, and most women don't know this, but the question is, can we do the same but without surgery? Can we open the tubes or unblock them without surgery? Interestingly enough, the answer is possibly yes. There's a pelvic physical therapy called the Wurn Technique, spelled W-U-R-N. Not sure how you pronounce that exactly, but it's a very specific massage therapy that's designed to actually change the disposition and detach adhesions around the tubes and the uterus and the ovaries and return the pelvic organs to their normal pain-free functioning. Obviously, it's a form of alternative medicine, but it has offered quite dramatic improvements as far as improving sexual function, treating endometriosis, pelvic inflammatory disease sequelae, pelvic spasms, including tubal obstruction. This specific massage technique focuses on decreasing pain and increasing mobility and the normal function of our pelvic, abdominal, and reproductive organs. This was developed by the physical therapist named Belinda Wurn and Larry Wurn, and the nurses that administer it must complete required training courses and be licensed to treat patients using this technique. Usually, the massaging nurse will apply very specific pressure over what is determined to be the problem area, and supposedly will need to do so over the course of 20 hours in 5 days. So that's a very long massage. I don't know about you, but that poor lady that's doing the massage is probably going to need the medal at the end of it. So obviously the person performing the massage must first do a natural assessment of the abdomen and the pelvis, determine where there is restricted mobility. So they're trained to look for normal. And then when they don't find normal, they find abnormal. They focus on these areas and they engage the uterine fundus, the side walls of the vaginal canal, using specific motions that are meant to soften and stretch the adhesions. Obviously, this type of massage also attempts to restore proper circulation. Now, interestingly enough, many physicians have seen great results for their patients where everything else had failed. So if you find yourself in a situation where you've tried everything and you do not want the surgery, or you've already tried the surgery and it didn't work, this might be a viable option. So we talked about the tube and how to reopen a blocked tube. But what about the uterus? Well, there are various procedures that can be done to treat a diseased uterus. a uterus that's not allowing implantation. Remember, this organ has to house the baby for 9 months, but before it houses the baby, it will need to allow the baby to burrow into its lining and make a home for it. Now, the main problem, a lot of the times, and that can actually impact tubal function as well, are the fibroids that are located around the fundus, the top of the uterus. If you Google fallopian tubes entrance into the uterus, click images, you're going to see that the tubes enter the uterus at the top of the uterus. So it's very likely that a fibroid located in that position, it's going to interfere with the entrance of the fallopian tube into the uterus. And most likely this type of fibroid will restrict and will block the egg entering the uterine cavity. What's interesting is usually the fibroids do not block the sperm passage. We're talking about a cell that is absolutely minuscule. You can only see it with the electronic microscope. Now, those little guys pretty much go everywhere they need to. So they will make it into the tube. But once the egg is fertilized into the outer portions of the tube, it grows. It starts dividing. And as it grows, it will become too large to pass through the super narrow opening that allowed the sperm to go through. So unfortunately, that is how the egg is implanting in the tube, causing an ectopic tubal pregnancy. So is there a way that we can test for these fibroids? Where are they located? What does the lining look like? And yes, I did talk about this in a couple of episodes back, but let me review this again. First of all, an ultrasound could give you a lot of information about your uterus. It is non-invasive. It costs about $200. The best timing to perform such an ultrasound will be right at the end of your period or around day 3 or 4 of your cycle. Remember, your cycle starts on day 1. That's when the bleeding starts. That's day 1. Now, your GYN doctor can also look at your ovaries, could count your antral follicles, the number of eggs you have at the beginning of the cycle. That's a lot of information there. Can look at the lining of your uterus because it's best to see it at its thinnest. Right after the period has come and go and it's shed. And we can see at that point if you have a thick lining, if you have a possible polyp. We can see if there's a fibroid that's bulging into the uterus. So on top of the antral follicles and the lining of the uterus, we can also evaluate the uterine size overall, its shape. Is it a unicornuate uterus, a didelphous uterus, a bicornuate uterus? We can also see its position inside the pelvis. Is there a severe angle between the cervix and the uterus called anteversion? So the uterus is anteflexed, flexed towards the bladder, or is it retroverted, flexed towards your sacrum? It could also see if the uterus is deviated to the right or the left, indicating already that there's possibly scarring. It could possibly find an abnormal ovarian cyst, or it could identify an ovary that's right next to the uterus, very intimately close to it, signifying possibly scarring and adhesions between the uterus and the ovary, which are very common in endometriosis. By the way, you cannot see endometriosis with an ultrasound, but when you turn on the color Doppler flow and assess the uterus that way, you can actually see adenomyosis pretty well. So there's a ton of information that your doctor can get from an ultrasound. Now, I'm not talking about an ultrasound performed by a technician in an imaging center that takes a bunch of pictures and send them over to the radiologist who reads the pictures. I'm talking about real live ultrasound done with your gynecologist or your reproductive endocrinologist. Now, a more direct inspection of the inside of the uterus, that's another very valuable test to assess the exact space and quality of the lining where the egg is going to implant. That is called a hysteroscopy, not a hysterectomy. They sound familiar or close together, but hysteroscopy is putting a camera inside the uterus. Now, the cost for the hysteroscopy is somewhere between $700 and $1,500. It's obviously more expensive than ultrasound, but quite affordable. And a hysteroscopy could be very useful. It is a very simple procedure performed under usually oral sedation in the office. It's using a sterile technique. And again, the GYN doc will insert a camera through the uterine opening into the uterine cavity to inspect it from the inside, and also can look at the fallopian tube openings into the uterus. Now, a lot of information can be gained by this procedure. Is there difficulty seeing the tubal openings? Are they closed? Is there a moderate or a large size fibroid, or maybe even a uterine polyp that's interfering with the implantation process? Is there scarring of the endometrium that can be broken down, dissected right then and there, allowing new tissue to grow with estrogen therapy prescribed after the procedure? Yes. So there's a lot of value for fertility just by doing this simple procedure if you have difficulty conceiving and we're not sure why. Now, coming back to fibroids that obstruct the tubes, performing a myomectomy laparoscopically, so again, camera to the belly button, there's an actual procedure, it's a surgery, you're put to sleep. So the myomectomy is when the surgeon makes an incision right on top of the uterus and starts gently removing the fibroid, making a very big effort to spare any uterine tissue that's close to the tubal entry, so we can allow normal pregnancy naturally after the myomectomy. Now, if we have a fibroid that obstructs at the fundal region of the uterus, the entrance of the fallopian tubes, that fibroid will either have to be removed or the woman can simply choose IVF. Again, not IUI. IVF, it's in vitro fertilization, not IUI, not intrauterine insemination, because the risk for an ectopic pregnancy with intrauterine insemination is the same as the one I mentioned before. The sperm is introduced and deposited into the uterus, and the sperm will get places, but the egg could be large enough to stay an implant in the tube with IUI. Whereas with IVF, in vitro fertilization, the doctor will recruit the antral follicles, will get the sperm from the male, will put them in a petri dish, an embryo will be grown, and after a few days, when the embryo is deemed to be at the right stage, the embryo will be deposited in the uterus, and it will implant where it needs to. Now, coming back to the myomectomy, at the time that the surgeon is removing the fibroids that impact the tubes, he or she can also perform a procedure called chromopertubation. That is when we inject the blue dye through a balloon that's already placed in the uterus, and then we can see immediately if the removal of the fibroid released the blockage of the tubes. I, interestingly enough, have 2 young women in the practice right now, and both have these type of fibroids right at the fundus of the uterus. And it's very hard to decide, should they do surgery, should they not do surgery? One of them is early 20s, nowhere close to wanting a pregnancy, but the problem is her fibroid is slowly growing. And we know for a fact is blocking her tubes because she already had surgery for a large ovarian cyst when the chromopertubation test showed that there is no passage of the dye, so her tubes are not working. So without removing this fibroid, she will never get pregnant unless she does IVF. And then the second woman is actually in her late 30s. She's almost 40. She's ready to have a baby, but she can't conceive, even though she's been trying. And the ultrasound is already telling me that one of the fibroids is in a location that's likely blocking one or both tubes. So now we're in the process of scheduling the hysterosalpingogram to confirm that. Now, both women are confronted with huge decisions regarding surgery. And again, this type of surgery is not necessarily guaranteed to restore natural fertility. And both women at this point, as it turns out, do not have funds for in vitro fertilization, and obviously would like to have as much of their care as possible covered by their medical insurance plans. And this kind of brings me to addressing the elephant in the room and also addressing the key issue that concerns many men and women who seek fertility treatments. What is the cost? How much does it cost to help you get pregnant? Well, that could be anywhere from a couple of $1,000s a year on fertility consultation and tests, not including a couple of $100 more or less a month for vitamins and supplements that are necessary to help you achieve your goal, to as high as over $100,000. What? $100,000 to get pregnant? That much? Yes. During my own personal fertility journey, I met a couple who spent over $200,000 on fertility treatments. And mind you, this was 10 to 13 years ago. Adjust that for inflation, that's a stupendous amount of money. They had multiple IVF cycles and they had not given up hope. Now, the odds were not in their favor, and she was considering adoption at this point or donor egg, but she really wanted her own baby. And she had the means, the time, the energy, the dedication, and the perseverance to go through with all these treatments and subject her entire life to major changes in her body, all in order to allow a baby to come into her world. So in many cases, and for many couples, the fertility journey can be a very costly journey. For many couples, money is not an issue. They're willing to throw everything, a lot of resources, a lot of expenses and money and time at achieving their dream of becoming parents. But for the majority of fertility challenge couples, they don't have unlimited resources, and they would like to invest their money wisely in things and procedures and treatments and vitamins that they hope are going to work for them and give them the carrot at the end of the stick, that beautiful, healthy baby. Now, what many couples fail to realize when they start this journey and they look into how much is going to cost them, or they ask, well, how much is the fertility consultation? How much is the ultrasound? How much is the vitamins a month? How much is the hysteroscopy? Now, what many women, because they're the most likely to seek the consultation, is the fact that this is just the beginning of a very costly endeavor. The bottom line is that bringing a baby into this world, taking care, nourishing, educating, and helping a newborn develop into a beautiful, intelligent human being is a very costly process. Now, I'm going to throw a number at you, and please don't think I'm crazy and I made this stuff up, because you can find it easily on Google. But statistics estimate that in 2023, based on the current rate of inflation, on current economical conditions, raising a child until the age of 18 will cost a couple about $350,000. That is the cost of a house. So if you don't believe me, please Google how much does it cost to raise a child until the age of 18. Now, most experts and studies agree that it depends on the state that you're bringing up the child. It's much more expensive to raise a child in some states like Hawaii and California than other states. And most experts agree that the majority of the costs for raising a child is actually child care. Now, if it costs you $20,000 to $40,000 a year to pay for child care, consider how much money you have to make by working and what is remaining to you after taxes to make that child care worthwhile. That's a whole different subject on a whole different topic. And honestly, I am a very big proponent of parents raising their child themselves, not allowing a stranger to do it at a huge financial cost. I just don't see that that makes sense. And I can't believe anyone would be more in love with their career than their child. And considering today's demands in the workplace, it's unlikely that anyone can be a successful professional, have a successful career, whether it's a man or a woman, and have plenty of time for the children. Now, most likely children will benefit greatly from one of the parents staying home and dedicating the time, the attention, the effort, the energy that they require to turn into these beautiful, intelligent, generous, confident, and socially skilled human beings that we all want. So again, there are many things to consider when deciding to have a family and raise children. But many people don't think about the big picture. They just want to have a baby. So let me get back to what I was talking about, which is the cost of fertility. So considering the huge bucket that you're going to put money in for the next 18 years, look at the fertility costs like a drop in the bucket. And if you're not mentally, emotionally, and financially prepared to do so, it might be a very rude awakening when time comes to find out that you actually need help conceiving, and it's going to cost you money. Now, I am a big believer in 1 ounce of prevention is worth a pound of cure. So consider looking into your fertility as a couple or as a woman or a single man a few years ahead of the desired date of conception. And consider it an investment in your fertility. Consider it an investment in your health. Being able to conceive naturally is the pinnacle of a normal state of health for both a woman and a man. There are some very strange and interesting circumstances where a very ill and severely malnourished woman is able to get pregnant in spite of their desire not to get pregnant. That's another subject for another day, another topic for another podcast episode. However, what I just said prior to this is true. Your body has to be perfectly healthy and have great hormonal balance in order to be baby friendly. So consider looking at your hormones 1 year, looking at your uterus and vaginal microbiome health, doing an ultrasound, some vaginal swab testing in another year. And then last but not least, always check generally once a year as you approach conception, what your thyroid looks like, what your vitamins look like, your kidney, your liver, what are your inflammation markers, etc. And all of this makes total sense to do before you decide to embark on the fertility journey. And as long as you and your doctor draw the line and make it clear what is covered and what is not covered by your health insurance, some medical consultations and testing might be at cost to you, but consider these costs as an investment into your health and into your optimal fertility if you're a woman under 40 and want to have your first baby, or if you're over 40 and want to add more children to your family. Please don't take fertility for granted. We live in a world of our own making, and fertility for men and women is on the decline and becoming a serious health issue. Many experts are raising this alarm, and I sincerely hope that this episode is not falling on deaf ears and will make some men and women consider taking action early and looking into fertility testing, fertility vitamins, and fertility lifestyle. If you'd like to maximize your fertility potential and have a consultation, please call our office to set up an appointment. Our phone number is 805-379-9110, or you can go to our website, www.herabeautyandwellness.com, enter your information in the AI chat, and one of our highly trained staff will contact you to answer your questions and help you make the appointment. I sincerely hope this episode has been useful and thought-provoking, and please forward it to someone you might know that could benefit from the knowledge I shared here. Thank you so much for listening. If you are one of my faithful listeners and you are finding value and enjoying these episodes, please feel free to leave me a review on whatever platform you're listening to. Also, if you find the content in these topics useful, not just to you, but to someone else, a friend, a loved one, or simply an acquaintance that you know could benefit from the knowledge I share here, please feel free to forward my podcast to them. If you live in California and you'd like to work with our practice to help you achieve your wellness goals, please go to our website, www.herabeautyandwellness.com, and request an appointment. It will be our privilege to help you in any way, shape, and form we can. Any suggestions on a topic of beauty, wellness, or anti-aging are welcome. All you have to do is go to the website, leave a suggestion into the AI chat, and I promise you if you ask, I will listen and add your suggestion to my list of topics that I want to get to as soon as possible. Please join our Facebook group, The Wellness Optimizing Warrior MD. It's a small growing community that focuses on wellness, on what's new, what's safe, and what works in beauty, wellness, and anti-aging.